Aaron is a neurologist at Sunnybrook and also an associate professor at the Division of Neurology at University of Toronto. Assistant professor.
I'm not there yet.
He completed a fellowship in ALS and neuromuscular medicine at Massachusetts General Hospital and began working in the ALS clinic at Sunnybrook in 2013. Aaron is a thoughtful and dedicated physician who's always has his patient's best interests at heart. It's a pleasure to work with him, with such a caring and compassionate doctor, and we're lucky to have him as part of the team at Sunnybrook. And with that, we may begin your presentation.
Thank you. I didn't write that last part. That was really nice. Okay, so I hope you can hear me. If you can't, just raise your hand and yell at me. So I'm going to talk about kind of the clinical and the medical side, just to give you an overview. And this is really just a small part of the care of ALS patients, but I want to just kind of introduce everything quickly. So, mouse, spacebar. Sorry. Okay. Gotcha. Okay, so we have simple objectives today for this talk. First of all, I just want you to give you a very basic understanding of the pathophysiology of ALS, that is how it happens. I'm going to give you an overview of the variability and the range of clinical presentation. And the thing I really want everyone to take home is that there is such a variability. Patients present and progress so differently. And I want to give you a sense of how that happens and what to look for. I'm going to give you an overview of our kind of diagnostic approach, how we go through making a diagnosis and making sure we're not missing anything else. And then finally discuss treatment options. Dr. Zinman, who's our clinic director, is going to be discussing kind of emerging treatment options and research down the road. So ALS was first described in 18-something. Sorry, it's blocked, but I think it was around 1867 by Charcot, who's probably like the most famous neurologist ever. If there was ever a celebrity neurologist, he's the guy, him and Oliver Sacks. He described multiple sclerosis. He described some of the hereditary neuropathies and ALS as well. But it really entered into the sphere of public consciousness, at least in North America, with Lou Gehrig. So Lou Gehrig was loomed large as a public figure. He played 14 seasons or 13 seasons straight without ever missing a game. And if you think about all the players that are put on disabled lists these days, he was really like, he never missed a game. He showed up every day. He was the picture of, health and strength. And he was struck down suddenly in his final season at the age of, I think he was in his late 30s. So this is why the disease is known by many still as Lou Gehrig's disease in the United States. So ALS is, we consider it to be a common rare disease. So the incidence and prevalence, so incidence is the number of patients that get a disease in a given year, and prevalence are the number of patients that have it at any given time. So 2 out of 100,000 get it per year, and at any given time, 6 out of 100,000 have the disease. And that means that about 3,000, up to 3,000 Canadians have the disease at any given time, and so that's not an insignificant amount. The average age of onset is around 60, but again, in the theme of variability, there is a huge variability. We see patients not uncommonly in their 30s, 40s, and certainly in their 70s, 80s. And there have been patients in their 20s and even their teens that have been diagnosed in this clinic. So there's no hard and fast rule, although most patients kind of cluster in their 50s and 60s. It can really come at any time of life. There's a slight male preponderance, so males tend to get it a little bit, about 50% more often than women. And the overall lifetime risk of an individual getting ALS is just over 1 in 1,000. So again, it's rare, but it's not unheard of. And most people, outside of the community will at least know someone at some point in their lives who is struck with this disease. There aren't that many identified risk factors like there are, for example, with vascular disease. We know that there's this age cluster, and males have a slightly increased risk. Smoking is associated with an increased risk of ALS. And then, of course, family history, because as I'll discuss later, 10% of ALS is genetic. So having a family history puts you at a slightly increased risk, certainly. And then there are clusters in the population where the risk is a little bit higher. So, I'm sure many of you have heard that veterans of the first Persian Gulf War have about a twofold, a significant increased risk of getting ALS from the early 1990s. And we haven't fully understood why. There's a number of different theories, but and then there's some other clusters of occupational exposures or previous medical history, like professional soccer players. One of the theories is just that they're constantly banging their heads. I didn't put it on here, but American firefighters, patients who have had electrical shock and trauma, slightly increased risk. So in terms of genetic, most patients with ALS, 90%, it's sporadic, meaning that it just happens. There's no obvious gene. There's no obvious family history. Unlike a disease like Huntington's disease, where the vast majority are genetic and there is a family history, but 10% are genetic. And if we, there have been studies that have tested the purple part of the pie chart here, all of the sporadic patients. And if you, do genetic testing on these patients, a small percentage of them will actually end up having a genetic mutation, but still the majority of patients with ALS get it for reasons we don't fully understand that are not genetic. So pathophysiology, just very briefly, I'm not going to get into the science of it too much, but in order to understand a disease, you have to, especially neurological disease, you have to have a basic understanding of the nervous system. So I'm definitely not going to take you through a neuroanatomy primer. I'm sure many of you remember that from your undergraduate courses. I like to think of the nervous system in very basic terms, and we only have to think about one part, the motor system. So the central nervous system is the brain and the spine. It's a little more complicated than that, but that's all we really need to know when thinking about this disease. And then you have muscles in the arms and legs and the throat and the diaphragm. And somehow the brain and spine have to tell these muscles to move, okay? So it's actually a very simple pathway. It's just two nerves. So we have an upper motor neuron, that carry the signal from the brain down through the spinal cord. And then we have lower motor neurons that carry the signal from the spinal cord out to the muscle. And this is true for any muscle you have in your body, whether it's your bicep or your diaphragm or the muscles in your throat. And so anytime you want to move a muscle, it's always a two-part pathway. So the upper motor neurons live in a part of the brain called the primary motor cortex. And I know this picture is kind of scary because it reminds you all of anatomy class, but the lower motor neurons live in a part of the spinal cord called the anterior horn. The reason I mention this is that I'm sure some of you have heard this term anterior horn cell disease or anterior horn involvement. And that's why we sometimes call it this, is because these cells that are involved in ALS live in the anterior horn of the spinal cord. So motor neuron disease, quite simply, and you're going to miss it because of that little picture there, but it's basically a disease where the cell bodies of the motor neurons die off, and for reasons we don't fully understand. But this is what we call a motor neuron disease, when these nerves die off. So why do these motor neurons die? The short answer is we don't know for sure. There's a number of theories, and it's probably in reality a combination of all or some of these. One of the leading theories right now is that there's some problem with the genetic processing in these cells. RNA is one of the important molecules that helps transcribe our DNA. And there's something wrong with the RNA, both in how it functions and how it kind of aggregates in our cells in patients with ALS. There's probably some inflammation as well, and there's some evidence for this. And then there's another theory called excitotoxicity. And this is what Rilotec, the medication that we have for ALS, targets. And then, without getting too much into it, basically that these neurons are getting overstimulated and undergoing a programmed cell death earlier than they should. So now that we understand the basics of the disease, that it's a motor neuron disease, we're going to talk a little bit about the clinical features. So the clinical features of ALS really stem from loss of these upper and lower motor neurons. So it's no surprise that if you lose the connection from the brain to the muscle, whether it's in the brain and spinal cord or whether it's peripherally in the arms or legs, you're going to develop weakness. After that, though, there's quite a difference actually between what upper and lower motor neuron involvement cause in these patients. So we're going to talk about lower motor neuron first, and you'll see this in the patients that you encounter when you're clinical. So with lower motor neuron loss, we get atrophy, which is basically shrinkage of muscles. And I'm sure you've all seen this when you see your patients. Does this have a laser on it? Yep. That red thing. So atrophy is basically shrinkage of muscles. And I'm sure you've seen, patients not just with ALS, by the way, anyone who has any kind of nerve injury or even disuse of muscles, their muscles will shrink. You see this kind of hollowing out of intrinsic hand muscles. You can see it in the leg. The shin bone sticks out, the calf kind of flattens out. And one thing that's somewhat unique to ALS is you see kind of shriveling up of the tongue. It kind of looks like a raisin. Many people have this kind of scalloped appearance because of teeth marks on the side, and that itself is not really atrophy, but it's kind of this scalloping appearance of the tongue. And really, muscle atrophy can happen in any muscle that's affected by this disease. Fasciculations are a very commonly thought of symptom of ALS, and as well as cramping, and they really both stem from the same issue. So fasciculations are muscle twitches, right? And they come from spontaneous firing of nerves that cause involuntary contractions of either small parts of muscles or large parts of muscles. That's basically what causes cramping too. So I was going to show a YouTube video, but last time I tried, it didn't work very well. But the truth is, I'm sure many of you have experienced, probably most of you have experienced fasciculations before in your calves after you work out, or those little twitches you get in your eyelids are kind of like a type of fasciculation. So fasciculations happen in people without disease too. And they can really be seen in they're not unique to ALS. They can happen in any condition where there's nerve injury. And it's really in ALS, you worry about ALS when you see them widespread and associated with the other clinical features like weakness and atrophy. And again, they're most commonly physiologic, benign. It's really more about the company that they keep when they're associated with weakness. So now we'll talk about upper motor neuron loss. So again, there's weakness, but one of the most characteristic features of upper motor neuron loss is spasticity, and our occupational therapist and physiatrist are going to discuss this a little bit later. So spasticity is really a type of stiffness. And patients experience this and describe it as stiffness and slowness in their movements. And patients who have upper motor neuron involvement sometimes don't have very much weakness at all, but it's this stiffness that can be so debilitating. Patients can be, if it's not managed, patients, because of their spasticity, can be wheelchair bound or even bed bound because the stiffness is so severe that they just can't move, they can't walk, transfer to the bathroom. So it can be debilitating. And this is something that's, an important target of symptomatic treatment. Hyperreflexia isn't really a symptom, and I think I left this in from a previous talk to medical students. It's a clinical finding, but patients with ALS have very brisk reflexes. So one thing you'll notice is that these are all motor symptoms for the most part. This disease mainly causes weakness and other problems with motor functioning. These patients tend not to get pain, and they tend not to get numbness and tingling. Pain, numbness, and tingling are prominent neurological symptoms that we see in lots of other diseases. ALS patients certainly can experience pain as a complication of joint issues like frozen shoulder, but it's not caused directly by the disease. And as physicians, as clinicians seeing these patients, this is one of the clues that helps us recognize this disease. We call it a pure motor syndrome, where they only have weakness, stiffness without the other manifestations of neurological disease. And this is when red flags start to go up for us and we start to think about it. So ALS can cause damage in multiple body, and it often does cause damage in multiple body regions. So we can kind of break it up into 4 areas: the face and throat, which we call the bulbar or cranial bulbar region; the arm, which is from the cervical spine, the neck; the trunk, which is from the thoracic spine; and the legs, which are from the lumbosacral spine and the spinal cord. And so this is, again, back to that theme of variability. There's a huge variability in how it presents. About 1/3 of patients present with weakness in their hand or their arm, 1/3 with weakness in their legs, and 1/3 with difficulty with speech and swallowing. And that's why it's often, confusing for patients, because they come to clinic and they see other patients who have such different manifestations. So one patient can't speak, can't swallow, but has perfect use of their arms and legs, and another patient doesn't have any issues with their speech, but they're in a wheelchair because their legs are weak. And so, especially at the beginning, the disease can often be hard to recognize and can look very different from one patient to the next. There's also a smaller group of patients that can present with isolated or predominantly difficulty with breathing. And some patients can present with cognitive dysfunction, which we haven't talked about yet, but I'll get into in a moment. So I'm going to talk a little bit about the bulbar or the speech swallowing onset, although our SLP, Anna, is going to get into this a little bit later. So one of the major manifestations is difficulty with speech, and that's basically slurring of speech. And patients can also have difficulty with swallowing, and sometimes they get, sorry, that shouldn't have said drooling there. And they can also get drooling as well as difficulty with swallowing or sialorrhea, and that's really a problem with clearing the secretions in their mouth. I'm not going to get too much into the respiratory symptoms because we have a whole half hour dedicated to that, but patients can often have this early on and certainly often later in the disease. Difficulty with their breathing, anything from shortness of breath to orthopnea, difficulty lying flat, problems with their cough, and then they, of course, run the risk of aspirating. I don't want to spend too much time on this. We're kind of focused more on ALS, which is where the upper and the lower motor neuron is involved, but you've probably also heard that term before, PLS, or primary lateral sclerosis, and some of you have probably heard of this as well. And I just want to kind of highlight that this is really a spectrum of disease. Some patients, similar to how it can start in different parts of the body, can present predominantly with the upper nerves involved or the lower motor neuron is involved. So some patients come to us and they don't have any twitching, they don't have any atrophy, their electrical testing is all normal. They really come in with stiffness, with spasticity, and maybe a little bit of weakness. And these are the patients that are often referred to as PLS. On the flip side, some patients never get that stiffness. Some patients never get brisk reflexes. They only have signs of lower motor neuron loss. And it kind of depends if you're a lumper or a splitter, if you give patients multiple different labels for the same thing. I think many practitioners now really consider these all variants of ALS. And sure, if someone presents like this and they never develop any lower motor neuron involvement after 10 years, maybe then you can call them PLS. But I think it's important for patients to understand that, these are all kind of variants of the same type of disease. And below here in smaller font, there are other motor neuron diseases that are not degenerative like ALS, that don't present like this. Polio for a long time used to be the most common motor neuron disease until there was a vaccination for it. And that would just involve lower motor neurons. And there's other hereditary causes. So one thing that kind of became more apparent in the last few decades is that patients with ALS can also have cognitive involvement. Initially, this was thought to be a pure motor condition without any impairment of cognition or of awareness. But in fact, there is some significant evidence to show that frontotemporal dementia, which is probably the second or third most common degenerative cause of dementia after Alzheimer's disease, is not all that uncommon. So about 50% of patients with ALS, when you do detailed cognitive testing, can have problems with attention, concentration, and working memory. So unlike Alzheimer's disease, where it's really mainly forming new memories and forgetfulness, these patients have problems with planning, with the frontal lobe functions, like planning, executive function, sometimes with behavior, personality, social graces, apathy. So this can be a real problem. And 15% of our patients actually meet criteria for frontotemporal dementia. And it's just tragic when patients present with both of these things together, because they're really grappling with two devastating diseases at the same time. And it's a huge burden on caregivers too. So those are the clinical manifestations. I just want to take you through, are we okay for time? So far? I just want to take you through kind of our diagnostic approach and how we arrive at the diagnosis of these patients. So I think, myself and the other doctors, the other neurologists that work in the clinic, we take this very seriously, because this is kind of the end of the line. They might have seen one or two other neurologists, and they're coming to us, and we have an important job. We really have to make sure that they actually have ALS and that they don't have something else. So we I think most of us engage in two processes at the same time. We try to rule in ALS, and we try to rule out other mimics. And it's actually often a pretty simple workup or set of investigations. They need an MRI of the brain or spine, depending on where the symptoms are. So if they're presenting with speech and swallowing problems, you want an MRI of the brain. If they're presenting with weakness in the arm, at least an MRI of the cervical spine, where those nerves come off of, and so forth. And it's important to do that to make sure you're not missing anything structural, like a slip disc or a brain tumor or a previous stroke, something else that could explain their symptoms. Because sometimes those things that you identify on imaging can actually be reversible or treatable. There's been more than one patient who we've seen who ended up just having a slip disc that was pressing on a nerve and pressing on their spinal cord. They have surgery, and although that's not ideal, it's better than being diagnosed with a relatively untreatable degenerative disease. Some basic blood work needs to be done to rule out mimics, but for the most part, this is unrevealing. And then, of course, we do our electrophysiological testing, which is referred by many as EMG. So I'm going to talk about that first. When you're referred for an EMG, you're actually getting two tests. You're getting a nerve conduction study, and you're getting the EMG itself, which is a needle test. So a nerve conduction study is a pretty simple test. You're basically zapping the nerve at one end, recording it at the other end, and just making sure that it works. So this thing here is the stimulator. These here are the electrodes that are picking up the signal. You zap the nerve, and you record at the other end, and you get a waveform. And that tells us something about the integrity of the nerve. And if there's damage to the nerve upstream, this nerve dies off and the wire does not give the same signal. What's probably even more useful is EMG, and I don't have a nice example of it, but EMG actually involves putting a needle into the muscle. And the needle itself actually has a tiny little recording electrode inside of it. It's basically like putting a microphone into the muscle and listening. And the reason we listen is that when there's nerve damage, when there's nerve loss, like in ALS, the muscle sparks. It starts firing on its own. It gives evidence of nerve damage. And so this is probably the most useful test. The thing I'll highlight is that This is only abnormal in patients who have lower motor neuron involvements, because remember, that's the nerve that actually plugs into the muscle. If they only have upper motor neuron involvement like PLS, this will be totally normal, or it can be. So to look at the central nervous system, at the upper motor nerves, we have to do MRI. And the thing that's actually confusing to a lot of patients is that the MRI is typically normal in ALS. I've had more than one patient show up to clinic and say, "Doc, I know I was referred for ALS, but my MRI was normal, so I'm assuming, everything's fine and we don't need to be here." And unfortunately, that's not the case. So typically the MRI is normal, but rarely when the disease is more progressed, you can actually see sometimes that those motor nerves are already scarred. So again, I'm not going to take you too much through the neuroanatomy of this, but you can see here, these areas of the brain do not look like the rest of the brain. This is kind of what the brain normally should look like. And these areas are where those primary motor nerves live, those upper motor nerves live. And that whitening is actually evidence of scarring and sclerosis. And when you follow those pathways down through the brain, you can see that there is, some scarring that goes down through the brain. You would never hang your hat on this part of the diagnosis, but this is a supportive feature that you can see sometimes. So we're going to talk a little bit now about the progression. Good for time. Okay, we're going to talk a little bit now about the progression in terms of what to expect. And again, in the theme of variability, the same thing holds here. So when you see a patient for the first time, one of the most logical and understandable questions that they have is, how long is this going to be? What can I expect? And unfortunately, we often can't tell them. There are statistics, and there are averages, and there are means, and those numbers are pretty scary. But the truth is that there's a huge variability. I'm following patients now in the clinic that, I've been there since 2013, that have been patients in the clinic probably since I was in high school. And of course, they're exceptions. They're rare, but it happens. So some patients present very gradually over time. They progress very slowly, and some very quickly, as I'm sure many of you who've worked in the hospital have seen. They can present within a few months and progress very quickly. What we do think is that most patients progress in a linear manner, meaning the disease tends not to slow down and it tends not to speed up. It tends to progress at the same rate that it's been progressing. And that's a small comfort to some patients, to at least know that things aren't going to creep up on them. They're not going to wake up one day unable to move something that was totally fine the day before. They will, for the most part, see the disease coming. This is kind of a graphic representation, again, back to Lou Gehrig, of his batting average in 1936 and 37, which are above the horizontal line, and 1938 when he was diagnosed. And you can see his batting average usually over the course of the season, 23 weeks, would improve and then kind of plateau. He was a pretty good hitter. But in 1938, you can see this, it's not perfectly linear, but you can see this kind of gradual decline that you could draw a best fit line through. So we don't use batting average to measure a patient's progression, but this is kind of I have always found this curve a little bit haunting. So for the majority of patients, the disease duration from symptom onset to when they pass away is 3 to 5 years, but there's a huge amount of variability. 20% live past 5 years and 10% past 10 years. Those numbers don't sound great, but it's something, and for some patients that provides hope that they may be one of those slow progressors. And we'll move on to treatment for the last bit. So I'd say the most important part of treatment is the multidisciplinary care. This is, there is a medication and hopefully more soon, but without question, and I'm not just saying this because these people are in the room, this is the most important part of care for these patients. So in our clinic, we have a number of different players involved. We have, of course, Danielle, our nurse, and there's often a nurse in the clinic, SLP, speech language pathology. We have the physicians from neurology, physiatry, and respirology. We have our dietitian, our assistive technology group. We have our occupational therapist and our respiratory therapist. And then one thing we're very blessed to have is our research team here. They're not technically involved in the clinical care exactly, but they really are, flush and integrated into the clinic. And I think patients really, certainly we appreciate having them, and patients really appreciate having that ability to talk about up and coming opportunities and to participate in research and what's being done in the field to advance our understanding of the disease. In terms of the actual, and so I'm not going to talk about what these people do. That's the purpose of today. And we're going to let each kind of individual group talk about that. But I'll talk about the medical treatment. And as you probably know, there's not that much to say right now, unfortunately. There's no cure, and we're very optimistic that there will be. Right now, there isn't one. There's a medication called Riluzole, or Rilotech, which has been around for 20 years. And it was published, this first article was published in 1994 in the New England Journal. And without getting into too much detail of how it works or what we see in it, we tell patients it basically slows down the disease by 2 to 3 months. And it's hard to tell patients that, because in some ways that doesn't sound like very much. The truth is, maybe for patients who progress over a longer period of time, the effect is proportionally longer. So if it's 2 to 3 months for someone going between 3 to 5 years for someone who progresses longer, it might have more of an effect, but we don't really know that. This is hot news lately. There's another medication called Edaravone, developed out of Japan, which is now FDA approved. It's not Health Canada approved yet, but we're hoping that it will be soon. So this is a medication that was shown to slow the progression of the ALS-FRS, which is kind of like a symptom score. It's a measure of severity of disease over time, by 33%. And that's pretty good for, it sounds, certainly in some ways sounds even more encouraging than Riluzole. I think an important thing that we're trying to, make people aware of is that it was only actually shown to be a benefit in a subset of patients. So patients who have very mild respiratory involvement, arguably no respiratory involvement with a forced vital capacity above 80%, and a kind of very classic pattern of early progression. But there may be more trials in the future with higher doses or a longer follow-up time that may show effect. And the truth is that it's possible that it will help other patients too. And I think it's approved in the United States for all patients, and we're hoping this will be the case in Canada too. I think Dr. Zimin will probably speak more to this later. Okay, so that's it. So, just to summarize, ALS is a motor neuron disease. It's a disease that kills or causes degeneration of these upper and lower motor nerves. And it causes weakness in the arms and legs, problems with swallowing and speech, respiratory weakness and spasticity. And although there are medical treatments, I think we can all agree, those of us that work in the clinic, that it's really the multidisciplinary and supportive care that's the cornerstone of treatment, and that the medical treatment is just one arm. And with that, I think we're done. Any questions?
It was interesting, the frontotemporal dementia prevalence. Was it correlated or related to when the person was diagnosed? Or was it regardless of age diagnosis?
Oh, you mean like what age they're presenting at?
Yeah.
I'm not sure offhand, although FTD in general, like for patients that don't have ALS, it tends to present a little bit earlier than Alzheimer's disease. So FTD actually has an onset often around 55, which is a common mean onset for ALS too. So I think there might be data on this, but I think if you looked at it, it's probably less common in patients who are in their 40s and 30s. But to my knowledge, it's not any more common in a particular cluster that I'm aware of. Any other questions? Okay, thanks everyone.